for which they are requesting credit. Further explanation will be at the end of the event, and use the chat box for questions to avoid interrupting the speakers. Now, this is very important to write down the start code, 0771. You'll need this at the end for your CME and CE events. We'll share it also a few more times in the chat. The objectives of the 5th annual TRDRP Smoking Cessation Day is at the conclusion of the lecture, participants will be able to, number one, recall at least 2 state resources to help take a behavioral health facility smoke-free and integrate cessation treatment under a lens of overall wellness, recognizing 2 or more ways to provide smoking treatments responsive to culturally, racially, and linguistically diverse communities. Identify 4 key milestones associated with tobacco cessation. Specify 3 types of medications used to reduce nicotine cravings. Recognize the 7 FDA-approved medications for cessation, and recall the 4 terms that reflect the spirit of motivational interviewing. Most importantly, we want to educate and inspire you to help your patients or clients to change their behavior around smoking. The agenda is going to be a great agenda today, jam-packed. We started with the welcome. I'm speaking now from Smoking Cessation on the Smoking Cessation projects in Los Angeles County, and I'm summarizing the CME and CE processes. And Norma Mtume will give a little presentation shortly. From 8:30 to 9:15, we have Catherine Benoit, the Deputy Director of UCSF Smoking Cessation Leadership Center, talking on some smoking cessation and behavioral health in California. From 9:15 to 10 o'clock, we have a great talk by Peter Selby, Milestone Approaches to Smoking Cessation. We have a short break from 10 to 10:10. From 10:10 to 11 o'clock, we have pharmacotherapy and tobacco dependence treatment with Frank Vitale, Director of the National Pharmacy Partnership. From 11 to 11:40, we have a fascinating talk that's really going to be influential on how the FDA views smoking, on titled Low Nicotine Cigarettes and Their Potential Role in the Tobacco Control by Neil Benowitz, who's one of the pioneers in this area from UC San Francisco. We have a panel on tobacco-free recovery perspectives from the field. We have another short break from 12:15 to 12:25, from 12:25 to 1:25. We have conversations about changing the use of tobacco products with Brian Hurley. And then from 1:25 to 2:10, we have Tasha Dixon talking about helping others quit. And we have a wrap up and closing with the CME and CE recap at 2:10. We have 3 fantastic keynote speakers, Catherine Benoit, Peter Selby, and Neil Benowitz. So people are really in for a treat today. These speakers are outstanding. So TRDP stands for the Tobacco Related Disease Research Program. It's funded by the University of California Office of the President. It's funded by tobacco tax. In 2018, there was 3 projects funded under the Community Practice-Based Research Implementation, including our grant. The other 2 were from UC San Francisco and UC Davis, and we went in touch with the collaborators on these grants. The goal of the TRDP Implementation Science Award is to connect health service researchers that can lead to system changes in delivery of smoking cessation services for low-income smokers, including Medi-Cal population. And our program officer is Norval Hickman, who's been absolutely very helpful in getting our grant to fruition. Our grant is entitled DHS DMH, Department of Health Services and Department of Mental Health, TRDP funded Smoking Cessation Implementation Project. We're embedding comprehensive smoking cessation programs into LA County clinics. So we're not like creating new clinics. We're trying to have existing clinics in Department of Health Services and Department of Mental Health give smoking cessation services. Our grant provides assistance in these community clinics. It expands integrated clinical programs with smoking cessation medications plus smoking cessation counseling. It's Department of Health Service IRB approved and DMH HSCR approved. We have several smoking cessation sites. We have 11 in the Los Angeles County Department of Health Services and the Patient Center Medical Homes, and 7 in the Community Mental Health Centers of Los Angeles County Department of Mental Health. There was randomization, where the intervention arm has 9 primary care medical home DHS sites and 6 Department of Mental Health sites. Treatment as usual means they are their control group. They get what's currently going on. 2 of them are the PCMH sites, and one is the CMH health science sites, health center sites. The ones listed are here. Martin Luther King, LA County are the 2 treatment as usuals. Roybal, Harbor, Carson, Harbor, Lomita, Hubert Humphrey, Mid Valley, Long Beach, Claude Hudson, High Desert, and Olive View. And in the DMH, the sites, the treatment as usual is Arcadia Mental Health, East San Gabriel Valley Mental Health, Harbor UCLA Mental Health, South Bay Mental Health, West Central Mental Health Center, West Valley Mental Health Center, and our newest one is the American Indian Counseling Center. Patients at any of these DHS or DMH, any of these DHA sites can go to the treatment sites near them. Treatments in PCMH or in DMH mental health will go to their existing clinics for the services. We do the intervention is includes expected practices and policies permitting evidence-based treatments. DHS has behavioral health clinicians that are delivering most of the delivery of the smoking cessation services. DMH clinics have also offered, the leadership has offered smoking cessation services. Both systems have access to medicines, nicotine replacement therapy, bupropion, and varenicline. There's ongoing training, technical assistance, and decision support from the DPH Tobacco Control, Department of Health Service, Addiction Medicine, and our TRDP funded clinical experts. So there's a lot of ways people can get help with getting their patients or clients to stop smoking. The study that we're involved in is wrapping up. Our recruitment's ending in November 2022. Incentives include up to $50 per year. You have to be 18 years or older, a patient at either Los Angeles County DHS or DMH, and smoking at least 3 cigarettes a day. And the patient or client wants to reduce or eliminate their tobacco products. So our progress includes that we've enrolled 338 study patients. We have over an 80% follow-up rate for the 3 and 6 months and a 79% follow-up rate for the 12 months. So most of the patients do stay in our study. Our recruitments have continued even through COVID. We have an expanded referral source, which includes patient self-referrals, pre-screened patient list generated from the record system, referrals from clinical providers, and the referrals can be sent 3 ways. One is by messaging the navigators through the DHS patient management system, which is named ORCID. A second is to send an email to the navigators at DHS email. And third is to use the multi-patient task list or MPTL for smoking cessation services. We have a new colleague who's extremely helpful, Rashid Alani, MD at Hubert Humphrey, and he's worked with DHS leadership and a lot of the DHS primary care providers to get them to increase the referral here, including we started a competition for the most referrals. So this shows the numbers, and it's a large amount of numbers that we start with, but we get a little less for the study. It turns out that we enrolled in the intervention sites in DHS, 155 patients, 74 in the treatment as usual sites for a total of 229 in DHS. In DMH, Department of Mental Health, we've enrolled 83 in the intervention sites, 22 in the treatment as usual sites, and 105 total. So our total comes out to 338. This shows the amount of cigarettes smoked as measured by per day, as measured by this timeline measurement. And you can see on the left, the first column, the group 0 is the control group. So these are the treatment as usual group. There was a slight but significant decrease in the amount of smoking even in the control group. It went from 10.8 to 9.5, and that was slightly significant. However, in the intervention group, there was a big drop in the amount of cigarettes smoked from 10.1 at baseline, 8.5 at 3 months, 7.2 at 6 months, and 6.4 at 12 months. And these were highly significant, as shown on table 4 on the bottom here. So I think we might have expected people to start re-smoking and increasing their cigarettes after like 12 months. It turned out they continued to stop smoking after as the months went by, which is a good sign. We've engaged in clinical staff and trained providers and staff to facilitate the 60-minute cognitive behavioral therapy smoking cessation counseling group, which we call KICASH. We've trained providers in both systems to deliver smoking cessation medications at all participating clinics. We've had a bi-monthly medical management for smoking cessation webinar led by our studies co-PI, Dr. Brian Hurley. This webinar is open to all DHS and DMH providers and gets a nice attendance. The clinics work closely with study coordinators, which are known as smoking cessation navigators, to connect patients with kick-ash and medication prescribers to ensure the patients receive the desired smoking cessation services. This shows a little bit more data, which I think, again, shows sort of the effect of our intervention, especially with medications. The graph on the left shows all the medications prescribed with time from when we started the study till now. The red is the control or the treatment as usual group, and the blue is the intervention. You can see that there's an increase in the amount of medications prescribed, more in the intervention group than the treatment as usual group. On the right side, it breaks it down by the different types of treatment, especially the nicotine gum seems to be increasing the most. The varenicline tablet is going up next, and the nicotine lozenge is going up third. So the nicotine gum is increasing at a faster rate, but in general, more prescribers are using smoking cessation medications in our systems, which I think is a very good sign. We've had 5 publications citing the grant. They're listed here. And these have, I think, have been high impact articles. Okay, I'm going to turn it over to my dear colleague, Norma Mtume, who's going to be talking about looking back, moving forward. And you
Hi, I'm Norma Mtume, and this is my story regarding community engaged research. More recently, I've been thinking about medical care in South Los Angeles from a historical perspective. I grew up in Los Angeles in a poor neighborhood. From childhood to early adulthood, I received some basic primary care at a local doctor's office. However, when we didn't have insurance and cash was low, it was off to the old county hospital where a basic visit would take an entire day. I remember traveling a long distance to see a doctor, especially for specialty care. We would take 3 buses to get to the hospital and the clinic until a county facility was built in our more immediate community when I was 22 years old. I remember smaller local hospitals where my siblings were born and some county clinics, but they didn't provide the care we needed. Only recently did it dawn on me that many Black doctors lacked the admitting privileges in major hospitals. Consequently, after providing
Folks can't hear Dr. Friedman.
offices, they sent their patients to hospitals where they were allowed to practice.
can't hear?
No,
No, I can hear it.
I'm getting the chat. It's very low.
Math and life science in school.
Yes,
I
very
loved
low.
education and running street races with the neighborhood kids. I decided that I wanted to teach math and physical education when I grew up. Consequently, I began Cal State University at Los Angeles with a physical education major and a math minor. As time went on, I realized that it wasn't just the body I was interested in, it was overall health. Not much had changed since I was a little girl. I wanted to help make a change to ensure poor people could be well. In my sophomore year, I became involved with neighborhood social services and helped to start and direct a free clinic in South Los Angeles. My interest grew to include a more holistic approach to healthcare, and I returned to graduate school to study more about health and mental health. During my career, I helped to establish and serve in leadership for 2 other community medical and behavioral health clinics in Los Angeles and Berkeley, California. 8 years ago, I became involved with Charles Drew University and the University of California at Los Angeles Medical School's research endeavors around community engagement. I was invited to work with the schools and their students to help them develop best practices to engage with their patients in the community. I work with basic science researchers who are hard at work looking for causes, developing treatments, and hopefully finding cures for many illnesses and diseases that plague our poor and under-resourced communities, like those in South Los Angeles. Here, research is being conducted with and not on communities. As an individual with a diverse background, I participated as a full partner on non-traditional research teams in what is called community engaged research. I serve as a community representative on advisory boards that oversee the overall projects. I have conducted interviews, facilitated focus groups, and participated in planning events to disseminate research results back to the community. Unfortunately, things still haven't changed much since I was a child regarding poor health outcomes in my community. Poor people still have the highest rates of disease, disability, and preventable deaths. For instance, the decrease in smoking cessation rates across the nation still are not translated to lower rates of tobacco use in African American communities. My work over the last 8 years has culminated in my latest project, where I will be working with the research team to implement smoking cessation services in Los Angeles County mental health and health services clinics. I no longer consider research as something mysterious, but as something that warrants my attention and involvement. I work now to help with educational and health systems change to reverse these trends to ensure a longer and better quality of life for those in my community. Health science research studies are important because they help us to better understand illness and disease and what prevention, interventions, and treatments might work best for various populations. Most community engaged research is paid for with your tax dollars. So why not join me? Learn more. Get involved.
Okay, thank you. Just a couple of notes following that. First of all, it's a little dated. It's been like 12 years since I started working doing this type of community engagement. And when I mentioned that the rates for decreasing smoking didn't happen as much didn't happen in the Black community. It did happen, but at much lower rates than other communities. So thank you all for joining us this morning. And those of you who have been on these trainings before, you've heard me talk and say pretty much the same kind of thing. But I keep saying it because people in my community are still dying and suffering. And I wanted to just say that we want to help set the stage for what we're going to be thinking about today, what we'll be learning, and how we will take that back and put some of this information that we're receiving and use it to put into practice, helping. Okay, sorry, I was a little distracted with that movie. Helping our patients and our clients to be able to reduce and change their behavior around smoking so that they can live longer and better and healthier lives. I spent most of my career building and helping to run nonprofit organizations in South Los Angeles and similar communities. And by similar, I mean communities where health disparities abound. As you all are probably aware, smoking has been shown to have a direct causal or significantly exacerbating effect on many illnesses and diseases. Moreover, research shows that smoking can be detrimental to all systems of the body. As a community engagement advisor, my key role in this project is to help ensure that we keep the real goal of our work at the forefront. We do the work we do to help our patients, our clients have a better quality of life. Bottom line, we want to help save lives. But some days I still feel like I'm a casualty of trauma and disparities. These are some of the reasons. My maternal and paternal grandmothers died from strokes, and one also had diabetes. One of them smoked. My mom was killed in an accident while working for Los Angeles County. An elevator crushed her. One brother was murdered about 6 months after mom passed away. One brother, a smoker, died from colon cancer after a botched surgery while incarcerated. One more brother had a series of strokes, and we suspect it was a stroke that caused him to crash his car on the freeway one day, and shortly afterwards, he died from internal injuries. Oh, and I'm just getting started. My sister died at the age of 50, around 7 years ago. She had Parkinson's, diabetes, hypertension, and asthma. Oh, but did I say she smoked? Her husband passed away about 3 years ago from cancer. He smoked. And I haven't even touched on the mental health and HIV/AIDS cases in the family and dear friends, most of whom also smoke. My dad, who was always my biggest cheerleader and hero, died from lung cancer 13 years ago. In 6 months, I watched him go from a robust 185-pound, fun-loving grandpa to 95 pounds and too weak to stand on his own. He covered the mirror in his room because he couldn't stand to see his reflection. To emphasize the addictive quality of nicotine, he had 3 heart attacks before he stopped smoking. By then, and unbeknownst to any of us, the lung damage had already occurred. Also, one of my dearest friends since 7th grade died 2 years ago after a bitter battle with lung cancer. She also smoked and had the hardest time quitting. And this year, I add another casualty, my first cousin who passed away 6 months ago from lung cancer. We were childhood playmates. So you see, my work with this smoking cessation project is personal. I realize that I am but a step away from being one of the statistics we'll hear about today. I want to help see that others don't have to watch family, friends suffer and die from smoking-related illnesses as I've done. The best plan is to prevent ever starting to smoke. The second best plan is to intervene as soon as possible. I believe that integrating smoking cessation services into medical and mental health clinics is moving Los Angeles County in the right direction. I'm proud to be a part of this team and look forward to better outcomes for patients struggling to change their behaviors around smoking. And I figured that I must be still standing and have good health at 72 years old for some reason, and so I continue to do this work. Again, thank you for joining us. Welcome.
Great. Thank you so much, Norma.
Right.
Any questions for Norma or comments? Okay, so we want to especially thank the California Tobacco-Related Disease Research Program, TRDP, for funding us. The great Norma Mtume, Brianna Lopez, who's did all the AV work and helped a lot with the slides, and she's one of our other study coordinators. The grant, we have Catherine Benoit from UCSF Smoking Cessation Leadership Center, Peter Selby from University of Ontario, and Neil Benovitz from UCSF. Those are our 3 keynote speakers. We have Frank Vitale from the Pharmacy Partnership for Tobacco Cessation, Friends Research Institute, which is our agency, great agency where we our grants funded through. It's headed by Frank Voci, and great institution. Our CME is given by Beth Rutowski, Gloria Miele, Kimberly Valencia at UCLA's ISAP, and we thank the panelists, other presenters, and you, the participants. And with that, we'll go on to the speakers, I think. Okay, we'll talk about this in the end, but remember to stay to the end for your for the evaluations and the CME and CEs.